Welcome to the Practicing Clinicians Exchange podcast series on strategies for individualizing the management of inflammatory bowel disease. This is the last of 4 podcast episodes adapted from a presentation conducted during a PCE Gastroenterology APP bootcamp in April 2022. Each episode is eligible for CE or CME credit. To receive your credit at the conclusion of the podcast, please go to pce.is/IBD or click on the link in the podcast notes. This episode is certified for 0.25 ANCC contact hours and 0.25 AAPA credits. In this episode, Gastroenterology MP Dr. Nana Bernasko will explore health maintenance, long-term disease management, and collaboration with other members of the healthcare team to provide comprehensive, individualized patient care. Dr. Bernasko will begin this segment by reviewing optimal health maintenance. Let's get started.
So next we'll switch gears. We'll talk about the healthcare maintenance. This is just as important as a therapy that we're giving to our patients, right? Because we want to make sure that the medications that we're giving to our patients are safe and we prevent complications coming about from the disease process itself and the medications that we're using for our patient population. There are definitely evidence-based checklists available for your adult and pediatric patients. The Crohn's and Colitis Foundation has a great summary, a checklist that you can use. And then Cornerstones and IBD too has a wonderful checklist that you can use. But the 3 main areas of focus include vaccinations and infections, colon cancer screening, and other protections. So immunization rates for IBD patients are low, despite patients being at greater risk for vaccine preventable illnesses. There have been multiple papers that have been written about this. A lot of times the GI doesn't know if it's the PCP who's supposed to be doing those. PCP thinks it's the GI that's supposed to do it, and then the patient gets lost in the mix. But rule of thumb, avoid live vaccines when patients are immunosuppressed or considering immunosuppressive therapy. And this includes doses of prednisone greater than 20 milligrams daily. Vaccine response may be blunted in patients receiving immunosuppressive therapy. Of course, the type of therapy they're on may influence the degree of vaccine attenuation. And patients with IBD should receive age-appropriate vaccinations. So vaccines and infections, really there aren't too many vaccinations that we need to worry about that are live in our adult patients. A lot of times those vaccines have been given as kids. But if you do have to give a live vaccine, you want to make sure that you give it greater than or equal to 4 weeks prior to starting a biologic. We do now have a zoster vaccine, which is not live, and it has now been recommended for patients who are in immunosuppressive therapy who are 19 and above, or patients who are 50 years and older. With your non-live vaccines, you have your influenza vaccine, which all patients should receive. Keeping in mind that the nasal vaccine for flu vaccine is alive and is contraindicated in our IBD patients. Of course, COVID-19 has become a big thing the last 2 years. The International Organization for the Study of IBD came up with a consensus statement for vaccination of COVID-19 in IBD patients. Basically, patients with IBD should get the COVID vaccines at the earliest opportunity. These include your messenger RNA vaccines, your replication incompetent vector vaccines, your inactivated vaccines, and recombinant vaccines. These are all safe to give an IBD patient. Do not delay giving your IBD patient COVID vaccines because they're on immunomodifying therapies. Patients with IBD vaccinated against COVID-2 should be counseled that vaccine efficacy may be decreased while receiving certain systemic corticosteroids. So keep that in mind. But at the end of the day, your IBD patients, regardless of what therapy they are on, should get the COVID vaccines. So when it comes to malignancy risk with the IBD therapies that we have, I think we should just focus on the key ones here. This is a chart that you can go back and look at in the future. But pay attention here that basically your thigh appearance and you have an increased risk of lymphoma and non-melanoma skin cancer. You see a little bit of uptake too with your anti-TNFs, but not so much as much as your thigh appearance. Your JAK inhibitors do have a little bit of increased risk for non-melanoma skin cancer. And A lot of the therapies, or at least all the therapies, do not have a higher risk of breast cancer or solid tumor cancer. As you can see here, there's been a question about therapurins and urinary tract cancer. But in essence, basically, most of the treatments that we use for IBD have a low risk for cancers, especially solid tumor cancers. Moving forward, when it comes to colon cancer prevention, it is really essential to know that patients who have extensive colitis, this is described as patients with more than 1/3 of the colon that has been affected with IBD or have had their disease greater than or equal to 8 years, should have surveillance colonoscopies every 1 to 3 years, depending on that cancer risk, right? You want to use a high definition scope to make sure that you're looking at all the layers of tissue. You're not missing any flat polyps or anything that could potentially become colon cancer in the future. Cervical cancer, patients who are on systemic immunosuppression should have PAP test annually or every 2 years, depending on what their HPV risk is. And this is a discussion that they should have with their gynecologist to determine the appropriate rates of evaluation. Skin cancer, all my patients who have IBD, I recommend that they at least have 1 year of a total body skin exam, even if they're not on suppressive therapy, but especially if they're on systemic immunosuppression, they should have an annual skin exam. And then especially if they're on therapurins, make sure that they're wearing sunscreen. They're not laying out in the sun, going to sun and tan beds. Again, the best way to prevent skin cancer is to use sunscreen, right? Bone health is another big thing that patients with IBD should be evaluated for. Any patient with IBD who has low bone mineral density, has been on steroid greater than 3 months use or repetitive steroid use, they're a smoker, they have a maternal history of osteoporosis, they're postmenopausal, all these patients should be screened for osteoporosis. If it is negative at the time of screening, then you can screen them every 5 years. If they do have evidence of low bone mass, you want to initiate a therapy, whether it's vitamin D and calcium, increase their exercise activity, and then repeat that bone density scan in about 2 years to make sure that you are making an improvement in that bone mineral density loss. Again, as I said, you want to make sure they're on a calcium and vitamin D prescription supplementation, especially if it's deficient. What I do in practice is, just because I don't know how long my patients are going to be on steroids for, sometimes you have that difficult patient weaning off steroids, I just automatically start a vitamin D and calcium supplementation as soon as I start that prednisone or steroid use in them to help prevent bone loss. Other things you want to talk to your patients about: smoking cessation. A lot of times our patients have a lot of anxiety, they're stressed, and they use that smoking as a release to calm down their nerves. But again, smoking is terrible, no matter how you slice or dice it, and especially in our Crohn's disease patients. So you want to make sure that you're working with them towards smoking cessation if they are a person who smokes. Depression and anxiety, as I mentioned before, this is such a overwhelming disease. And so you want to make sure that your patients, you're making sure that they're not depressed, or if they are, you are referring them to the appropriate provider to deal with that. Because as I tell my patients, what affects here in the head definitely can affect the stomach in terms of IBS symptoms. So you want to make sure that the mind is at peace, and that also gives them a better chance of succeeding with their disease. As well as looking at all of these things, you want to assess for nutrition, right? You want to make sure the micronutrients are adequate. You want to make sure they're eating right. Their albumin levels are okay. So you look at vitamin B12, especially if they've had ileal disease or resection. Iron panel, a lot of times our patients are tired, and it turns out that they're really truly iron deficient or anemic. And like I said before, a lot of our patients will skip meals because eating may give them abdominal pain. So you really want to focus on that nutrition status as well. When it comes to therapy-related testing, each group of medicine has the appropriate therapy-related testings that you need to follow up on. You just don't give these medications to patients and say, again, see you in 2 years at your appointment. You want to make sure that you're doing the appropriate therapy-related testing to make sure that the medicine that we're prescribing is safe for our patients. So as I mentioned before, your patient is at an increased risk for bone loss if you keep giving them steroids. So you want to make sure that you're doing that bone mineral density scan. Glaucoma. other issues with eyes, with patients with steroids. You want to make sure they're doing the eye exam. When your patients are on aminosalicylates, an annual renal exam is very important. You want to do your creatinine, your BUN, make sure that they're not having any issues with their renal function. With your immunomodulators, I group them up with methotrexate as well. As you're probably aware, it can drop your white count. It can make your liver enzymes go up. And so make sure you're checking CBC, CMPs. Before you start that thiopurine, you want to make sure you check a TPMT enzyme activity. This is the enzyme that tells you how the patient is going to metabolize that medication. And so if the patient has a normal TPMT enzyme, technically you can give them the full dose of medication based on their weight. If they have an intermediate, then perhaps you may want to dose will decrease when you're putting that immunomodulator on. And if they don't have that TP enzyme activity at all, then you cannot put them on this medication because they will have major side effects on them. For your small molecules, depending on what you're using, you may want to check a CBC. Ozanimod is really the only one that you have to check an EKG. This is kind of out of the norm of what we typically do for our patients. So let that stick in your head. If you're going to put that patient on ozanimod, you want to do that baseline EKG to make sure you're checking for that cardiovascular AV nodule conduction activity. Make sure they're not in bradycardia before you start this medication. But you do want to do the same. Check their CBC, liver function, also their renal function. With ozanimod as well, that eye exam, because macular edema could be a potential side effect from this medication. So you want to make sure that you're doing that as well. And their pulmonary function test because of that pulmonary intermediation with this particular type of medication. One thing that's a little bit different that is not mentioned in here for your tofacitinib patient is that the lipid panel can be elevated. So you want to check a lipid panel with this medication, as well as your new medicine that's in that JAK inhibitor category, which is your upadacitinib. With your TNF biologics, with all your biologics, you want to make sure that you're getting a baseline CBC, baseline liver panel, or a CMP. For TNF inhibitors and ustekinumab, you want to check a hepatitis B panel as well, especially with your TNFs, because this medication can reactivate latent Hep B, and also with TB as well. You want to make sure that with your TNF and ustekinumab, you're checking your TB status prior to starting these medications. The bane of my existence. You cannot talk about IBD without talking about C. diff, because C. diff infections are increasing among patients with IBD. You have to know that patients who have IBD do not necessarily have to have been exposed to antibiotics or may have come in contact with patient with C. diff in order for them to develop C. diff. Patients who have UC tend to be at higher risk for getting C. diff. Active colitis in itself is associated with increased risk. Use of immunosuppressive therapy, especially steroids, increases your patient at risk for C. diff. So, best practice, anytime my patient calls in, they're having a flare or what they think is flare, I always test for C. diff because it can present as the same symptom of diarrhea in your patient who may think they're flaring, but in essence, they are having a C. diff reaction or a C. diff infection. And therefore, the treatment paradigm is different, right? If your patient has C. diff, you are not going to put that patient on steroids or increase your medication. You want to treat that C. diff. So it's so important that when your patient calls in that they're having diarrhea, the first thing that you're doing is checking for C. diff and not automatically placing them on steroids. And also screen for recurrent C. diff infection if diarrhea and symptoms of colitis persist or return after treatment. It always has to be in the back of your mind. Working together with primary care is so essential to the long-term management of your IBD patient, right? You want to make sure that patient has all their vaccinations up to date. In fact, when you get that IBD patient, make sure that they have an established care with a PCP. I can't stress that enough because you'll end up getting all the phone calls for everything that has nothing to do with IBD. So it's so important that you make sure that patient has a PCP. One, work with that PCP to make sure all vaccinations are up to date, including your COVID-19 vaccine and your annual flu vaccine. It's important if you can make sure that they're up to date with all their vaccination prior to immunosuppression. Again, some of these vaccines are a little bit blunted if they're already on immunosuppressive medication. So when you get that patient, just look at their vaccination history and fix everything that has not been already up to date. Their household members also need to receive the flu vaccine. Screen for osteoporosis at diagnosis and periodically after diagnosis. Annual skin checks, even if they're not on any immunosuppressive medication, but even so, if they're on immunomodulators and TNF inhibitors. Surveillance colonoscopy. Remember, your patient is not that average patient that has to wait till age 45 to get their first colonoscopy. Look at when they're diagnosed, the disease, the extent of disease within their colon, and then come up with that plan to survey their colon 8 years after disease symptoms. Or if they have PSC, which we didn't mention before, which is primary sclerosing cholangitis, that patient falls into a little bit of a different category. That patient is going to need annual surveillance of their colon because PSC puts that patient at a higher risk for colon cancer. So again, PSC yearly for a patient with extensive colon involvement, you're looking at 8 years after symptom development to screen them. Your eye exam for patients who are using steroids or an ozanimod. Depression and anxiety. Again, most of your IBD patients may not tell you straight up that they're depressed or anxious, but I can guarantee you that if you ask them and probe later, you will find that they do struggle with some of this. And then smoking cessation. Again, we've been talking about this since, we found that smoking can cause lung cancer. It is very detrimental also to your IBD patients. So make sure that you're talking to them about smoking cessation and work with them towards that goal. And your primary care provider can be that person that works with you with this. So boot camp takeaway, make sure your patients are up to date on all immunizations, preventative care and colon cancer screening, cervical cancer screening, and skin cancer as well.
Thank you very much, Dr. Bernasko, for that excellent presentation, and thank you to the listeners for joining us. Tune in to the other episodes in this series to learn about diagnosis and classification, treatment goals and targets, medication options, navigating therapeutic challenges, and much more. You can access those as well as claim your credit for this episode by visiting pce.is/IBD.